Hello. Going to start the next session. I'm Steve Burrell. I'm a nuclear medicine physician in Halifax, and I'm chairing the session. And it's on liver-directed therapies, where and why. So we have two speakers, and our first is Dr. Amol Mujoomdar from London Health Sciences Centre, where he's an interventional radiologist who does lots of liver-directed therapies.
Thank you. All right, so, and just being the novice in the room, having driven on the 401, to advance the slides, I just do it myself, or?
Yeah.
I was full focus on getting here.
That's forward.
Excellent.
That's a back if you need to back, and that's actually a laser pointer.
Perfect.
Yeah. Okay.
Not so focused on how to give the talk. All right. So, as I mentioned, I'm one of the interventional radiologists in London at London Health Sciences Centre and West University. Just, a few disclosures, some of which are kind of relevant to Y90, but the bigger disclosure is I'm going to give this talk about Y90, and I just anticipate the flood of referrals and people kind of accosting me in the hallway. So Y90 is not currently funded in Ontario. For those people that live in Alberta and BC, you're lucky. It is funded in very limited instances, more so for a primary liver cancer, but neuroendocrine does fall under that in very specific scenarios. I am working on it with a colleague from UHN in Toronto, but change occurs provincially and with CCO in a bit of a slow fashion, but it does happen as we see over time with the radioisotope therapies. So I just want to talk a little bit, just some general stuff about the role of the diagnostic and interventional radiologist on the neuroendocrine team. And I'm going to just do a very brief overview. It might be a little bit of an overlap with Dr. David's talk about the RFA and other types of transarterial therapies. When we say transarterial, it's sort of liver-targeted therapies where we go through the blood vessels. And those particularly involve what we call bland embolization, where we just use bland particles that of a particular size, where we're treating tumors, where we add chemotherapy, sometimes to particles or with an oily substance, and the Y90, which I'll spend most of the time talking about. And we'll talk a little bit, what is Y90? Sort of these terms are not so easy to understand. Embolization is kind of a dirty word, and radioembolization, chemoembolization. What exactly does this mean, and how does it work? How is it delivered? What's the patient experience in all this? What does a patient have to go through? What does a therapy entail? Talk a little about the risks and side effects, and how does it compare to just what we say bland embolization or transarterial embolization or transarterial chemoembolization. So the role of radiologists, not always a well-known, but I think, might be debatable who we think are important or not important. But I think it has an important role on the team. No more important, but certainly an important role. And the diagnostic radiologist is really looking at all the imaging, okay, and interpreting whether there's a response to treatment. And it's an important role, because if you say that a treatment has not worked or that something has progressed, that's a major impact to patients, because they'll be stopped on that therapy potentially and started on something new. And then there's the interventional radiologist, what I spend most of my time doing, and that's the physician who performs the image-guided procedures, usually with ultrasound or a CAT scan or live x-rays, what we call fluoroscopy. So where would you meet an interventional radiologist during the course of your journey? Well, maybe at the start with a biopsy. A lot of these diagnoses are made in patients with a biopsy, a lot of times through the liver, either with ultrasound or CT guidance. Sometimes we're seeing you as in a therapeutic capacity to burn tumors with different technologies like RFA or microwave, or to do these transarterial therapies. Sometimes we're involved in the journey for venous access procedures, which is not as or less common in the neuroendocrine world, but for putting in ports and PICC lines and things like that. So this is kind of our local team. You see it's a small team. In fact, one of them is not even really part of the team. He's one of our fellows who's now gone back to Saudi Arabia. But it's myself and one of my radiology colleagues, Dr. Wiseman, who's also an interventional radiologist with myself. We kind of run the neuroendocrine or the imaging side of the neuroendocrine team, and I happen to chair it with one of my surgical colleagues. And the IR team itself, the larger, broader IR team, is a large group of people, and it really takes a village. So our area, we have physicians, we have x-ray technologists, we have nurses, we have our receptionists and our facilitators, and we all really have the same goal in mind, is to really deliver high-quality care. So now we'll kind of talk a little bit about what are the different transarterial therapies for metastatic neuroendocrine cancer. So we'll just start a little bit with chemoembolization, bland embolization, not to take anything away from the next talk, but it's just the basics. It's a treatment that involves doing an angiogram. So just like people get angiograms of the heart when they have heart problems, we do an angiogram of the liver, okay, going through the blood vessels, shooting X-ray dye, and injecting either just bland particles or sort of synthetic shavings of, what we call polyvinyl alcohol, or we take a chemotherapy, usually doxorubicin, mix it with an oily substance, along with some X-ray dye, and inject it into the liver. When we do chemoembolization, we do also follow that with a kind of a bland embolization. Generally, it involves an admission to hospital. In our institution, we do it the day before. We kind of tune the patients up and then treat them, and then most people will go home the next day, but some people will stay in hospital just for symptom management. And we do this procedure in an interventional radiology suite with live X-rays. So this is I like this picture because it kind of conceptualizes what does this mean, right? So what does all this mean? Well, I guess I should use here, not my screen. We can kind of see, going through the groin. You can feel your pulse there in the groin. That's kind of our mainstay, although we've moved a lot now to going through the wrist as well. It's kind of a patient-friendly option that doesn't require bed rest. But going through the femoral artery in the groin with X-rays, sort of snaking our catheters up and finding the blood vessels that feed the liver. And then we do an angiogram, and that's kind of what an angiogram looks like, where you sort of see this, it's sort of subtracting everything out of the picture. So all we're seeing is X-ray dye in this sort of represented by these black lines. And this is kind of blood supply to the liver, and you can see a big tumor in the liver, okay? And we're sort of taking advantage of the fact that these tumors are fed by these arteries. And that's typically what we would do is kind of put a little catheter, a tiny little plastic tube that would go into that blood vessel and blast the thing with this chemotherapy or bland particles or Y90. So how does that work? And why does that work? Well, when we're doing bland embolization, we're kind of choking, and killing the blood supply of the tumor. And sort of, I call it, the choking effect. When we do chemoembolization, it's a bit of a 1-2 punch. So the chemotherapy is directly toxic to the tumor cells, but then we also choke it of its blood supply. What's better? Well, that's a bit debatable. Every center is a bit different. So at our institution, we mostly do chemoembolization, but I know, in Toronto, they'll mostly do bland embolization. Am I right and they're wrong? Probably, but not. Honestly, it's probably more, in the literature, it's a bit of a wash. There's a trend to better outcomes with chemoembolization, but a lot of it is your local practice, your local experience, and that's kind of how we've been operating for many years. And this is something that they've been doing in London well before I got there. So that's really been our mainstay. So what about Y90, right? So you guys came here to talk about Y90 or hear about some Y90. So really the rationale for Y90, okay, is that we know radiation works well in cancer, right? So it can be lethal to cancer cells if delivered at sufficient doses. The only problem with the liver is it can be very, toxic to the liver. The liver is very sensitive to radiation. So how do we kind of, meld those two kind of goals, right? To sort of maximize dose to tumor, whereas minimizing the dose to the normal liver. Well, you have these kind of tiny Y90 bearing microspheres, okay, that can kind of deliver a high dose of radiation. So they're very, very kind of high dose point sources of radiation that kind of preferentially localize into tumors just by the sheer nature that, tumors tend to be fed by these arteries. So when you inject chemo or Y90 or particles, they tend to go into the tumor cells. And you will sort of preferentially have Y90 go into tumors, emit a high dose radiation while sparing the normal liver, okay? As opposed to, giving external beam radiation to the liver, whereas that's it's less precise or less targeted. So that way you can sort of deliver this high dose of radiation. So the kind of commercially available products for Y90, it's either these little glass or resin microspheres that are impregnated with this Y90, and they can really, the science behind it, it gets a little fancy, but really it's a very kind of short distance of radiation, really up to 11 millimeters in range. And the half-life is fairly quick, about 2.5 days, and then it decays to a stable radioisotope. This has actually been around for quite a long time. It was, and Canada sort of led this. It was Health Canada approved in 1991. And we actually even did Y90 in London back in the 90s when this sort of came about. Unfortunately, those good old days are over. But and then it's also approved in the U.S. by the FDA. So this is not a new product by any stretch of the imagination. And that's just kind of from one of the companies to just kind of show that schematic of this tumor with the blood supply and these little Y90 spheres impregnating the small blood vessels of the tumor and emitting this radiation. So what's the patient experience? So some people in this room may have already undergone an embolization procedure, okay? So it's fairly similar to a bland or chemoembolization procedure. The only difference, and once again, this is center specific, but it's an outpatient procedure. There's no real admission to hospital required. And involves 2 or 3 parts, so 2 or 3 separate outpatient visits. The first day is kind of a planning day. So you come to hospital, you get an IV for some kind of pre-medication so we can sedate you, and you get a liver angiogram. So we either go through the wrist or the groin, through the blood vessels, shoot some X-ray dye to kind of map things out, and we use that in conjunction with the CAT scans or MRIs that people have had to kind of figure out the anatomy a little bit of the liver, and everybody's a bit different. So we have this classic textbook that we all learn in medical school called Netter, which everybody, or it's more for the older generation, I should say. The new guys don't have that, but, and I always kind of joke with the medical students, whatever Netter told you, he lied, because everybody is different, right? So people have different anatomy, different variations, so that's part of the planning that occurs. And then we also inject a radioactive kind of substance that day on the planning day, but it doesn't do anything in terms of therapy, okay? It's simply to see how much is shunting into the lungs. And we use that information. I also kind of sit down with the CAT scans or MRIs and calculate the volume of the liver, the volume of what we're treating, and we take all that information to figure out the dose. And we use that in conjunction with our nuclear medicine colleagues and to kind of figure out, for person X, what is their individual dose of Y90. And then we order the product, and usually about 1 to 2 weeks later, we would plan to do the therapy, which is basically, for the patient, it's the exact same experience. You come to hospital, you get an IV, you get some medications, we go through the groin of the wrist, do the liver angiogram again, and then, but this day, we actually deliver the particles, okay? And then usually, I keep people for about 2 hours, and they go home, okay? And before they go home, we do some pictures in nuclear medicine and call it a day. What are the risks? Well, the risks are fairly similar to a chemoembolization procedure, okay? So anytime we start poking you in the wrist of the groin to get into blood vessels, you could bleed, okay? But that's a fairly low risk. We'd say 1% or less. And somebody who does this a lot on a day-to-day basis, it's fairly rare that we have to do anything like a blood transfusion or have a real, what we'd say, clinically significant bleed. We could also theoretically scrape or damage blood vessels, but once again, this is what I do for a living. Most people with the neuroendocrine disease have nice, good blood vessels, so that's fairly rare. An infection could happen, infection in the liver, okay? That's also fairly low, and it's actually lower with Y90 than with the chemoembolization or bland embolization. The big kind of scary thing is an ulcer in the stomach or an ulcer in the bowel. But I can tell you in practice, this was described early on, so lucky for you guys, they did tons of these worldwide, so everyone else was the guinea pig, and they kind of sort of honed their technique. So it's actually really rare. In 2017, it's very rare for people to have an ulcer, and a lot of people at the meetings that we go to say that they haven't seen a case in 10 or 12 years. But certainly, we don't want to see a case, so we're very, very meticulous in our technique because it's a fairly devastating complication. Those ulcers take forever to heal. You can imagine having this little pinpoint radiation source just going bananas in the GI tract. It's a challenging problem. But I personally have never seen a case, don't want to, so I will be extremely careful to avoid that. Liver failure could happen. It's pretty rare. We tend to select the right patients for these type of therapies. We wouldn't pick somebody whose liver function was compromised or they would be at risk of liver failure because you can predict a lot of these in advance. And the other thing that's unique to Y90 is what we'd say a radiation-induced liver disease, which kind of induces kind of a hepatitis of the liver. People feel ill, they have nausea, vomiting, and it can be kind of a devastating complication. So what are the kind of side effects? If you had a Y90, what are you going to feel tomorrow, okay? To be honest, it's a fairly painless procedure other than the freezing and things like that. People kind of just go home and they're like, oh, it's pretty anticlimactic. As opposed to a chemoembolization or a bland embolization, which, people aren't loving me that day. I always say the day of the chemoembolization is a rough day. People feel sick. They feel like the flu. They're barfing. We kind of give them a lot of medications in advance, but they're not happy campers. So I usually avoid them that day and just throw the meds at them and wait till the next day when things are a little bit better. And then, but with the Y90, that's less common. People say pain is in the literature, they say it's common. In my experience, I don't really find that's true. Really, the biggest thing is fatigue. People will go home and they just feel like the wind's knocked out of their sails. And there are some medications that we can give to help that, like particularly steroids, to kind of perk people up. But fatigue is sort of the most common thing. But some people get these sort of mild flu-like symptoms. And there are some precautions with the Y90. Okay, it's not like the radioisotope therapies that are secreted into urine or saliva sometimes or things like that. So the Y90 does sit in the liver, and the radiation, it's not a dangerous radiation to other people. You're not isolated from the general population, but you do have to have some kind of precautions. So they just recommend that you don't sleep in the same bed as your partner for about a week. That you try not to sit beside somebody for more than 2-hour stretches. What I usually tell people, if you've got a 3-person couch, just kind of sit on either end and call it a day. I haven't had Y90. That's kind of how me and my wife do it anyway, right? So the dog's in the middle, and probably avoid the dog on the lap too. Yeah, and we try and avoid contact with children and pregnant women for about a week. How does that compare to bland or chemoembolization in terms of efficacy? So there's a fairly similar, in the literature, survival benefit in comparison to chemoembolization and bland embolization. The scientific literature is variable. There are certain centers that, publish their data, and you almost scratch your head and you say, really? Are you, that's incredible? And then, you almost wonder, are you selecting a little bit? But certainly, overall, it's probably fairly similar. There's really been no head-to-head trial comparing all three. There's a trial ongoing right now based out of University of Pennsylvania where they are trying to look at this, and I think it'll be challenging, but particularly in the States where you can kind of get what you want. It's hard to accrue patients to say, I'm going to put you in a trial, and when they can just, their insurance will cover all of it, so they'll say, well, what's the point, right? So that can be a bit of a challenge, but they are trying to study that. The advantage really with the Y90 is the side effect profile. It's just so well tolerated. If it was like me or my family, I'd certainly would love, and obviously the right patient or the right setting to give Y90, because it's sort of a one and done type of situation, whereas the chemoembolizations and the bland embolizations we do a lot over time. And then really, other than the fatigue, the side effect profile is quite good. The disadvantage, though, in our public system is cost. Okay, so I will hurry up. And you can really only do it once or twice, given the radiation threshold of the liver. I'm just going to fly through this, all right? It's going to be fast and furious. Okay, so who's a candidate? We've talked a lot about the importance of tumor boards. We have one in London. We have lots of regional participation, and we also participate in the provincial tumor board. We don't really talk about Y90 so much. It's more geared towards the PRRT and to kind of challenging patients. And who should we really be treating? So at our site, we tend to focus more on the lower grades, the G1, G2s, with liver-only disease or liver-predominant disease. We also patients with functional disease that are not candidates for operations, because that certainly works well. And then we also have to say, what are our goals of care, right? We ideally want to prolong life. One of the other speakers alluded to quality of life, not just prolong your life and you're hanging out in bed, hanging out with a bucket because you're barfing because I embolized you. We want good quality of life, okay? We also want to improve patient symptoms, prevent disease progression. And the carcinoid syndrome, we also worry about heart valves. We want to prevent any kind of valvular disease, and by controlling those hormone levels. Huge liver tumor. This just kind of shows what does a Y90 look like. There's a big white tumor here. Hopefully, everyone even in the back of the room can see that. Big Goomba tumor. This, not a patient with neuroendocrine cancer, with primary liver cancer. It's my poster child that goes on every Y90 talk. This is what an angiogram looks like, which we saw earlier. Oops, go back one. Anyway. We inject the Y90. I'm no nuclear medicine doc. They're smarter than I, but big bright spot means Y90 is in the tumor with lower uptake around. And over time, you can see this particular guy, being my poster child, had an amazing response. Right on these CAT scans, the tumor is just not bright anymore, and over time, it's just shrink, so that it's basically gone. So normally, this is not a curative type of procedure, but in this gentleman, it was. And next steps, we're certainly going to advocate to have this therapy funded, working with CNETs and CCO, and also just to kind of advocate the local provincial care or provincial levels to really increase awareness for neuroendocrine and the importance of multidisciplinary care and tumor boards. So certainly important. I just wanted to mention really quickly, you know, we had a great medical oncologist that I work with at London Health Science Center who passed away, and certainly just wanted to acknowledge it's been a great loss locally. And in conclusion, I can kind of just skip all this, but we certainly want to improve access to things like Y90 because it is a great therapy potentially for patients. So thank you for your attention.
Thank you.